Okay, welcome back, everybody. We pick up today's podcast with a discussion of the pancreas. Now, notice that this organ lies behind the stomach and wedged between the duodenum and the spleen. Okay, um, it's both an endocrine and an exocrine organ. It has a head, a body, and a tail. The head is the area tucked into the duodenum, as you can see here. The tail is near the spleen. The endocrine function is carried out by pancreatic islets that contain alpha and beta cells. The alpha cells create a hormone called glucagon, which has the ability to raise blood glucose levels, and the beta cells produce insulin, which has the ability to lower blood glucose levels, hence its moniker as a hypoglycemic hormone. The exocrine function of the pancreas is carried out by acini, and these form lobules separated by septa, and they are what create the digestive enzymes that help chemically break down the food that we eat. There's a series of ducts that port these enzymes ultimately to the duodenum. The intercalated ducts lead into the interlobulars, which lead into the interlobulars, and then these lead directly into the pancreatic ducts. The pancreatic duct joins the common bile duct and enters the duodenum at the hepatopancreatic ampulla, which is a little widened area where these two ducts fuse, and it's controlled by a sphincter called the hepatopancreatic sphincter, sometimes known as the sphincter of Oddi. Now, notice something, of course, about these two ducts. The bile duct and the pancreatic duct fuse and empty their contents into the duodenum. One of the risks that we run occasionally is the formation of gallstones. If the bile sits in the gallbladder for an extended period, it can crystallize, and those crystals can sometimes wedge in the cystic duct, which is the duct leading out of the gallbladder and into the bile duct. Sometimes they can actually wedge in the hepatopancreatic ampulla and impede the movement of the secretions of the pancreas and the gallbladder into the duodenum, and this can lead to pancreatitis as well as inflammation of the gallbladder and to some extent the liver. So what we do in that case is we use sometimes lithotripsy to crack the stones, sometimes we have to surgically resect, and sometimes we can get away with gallstone dissolving drugs. The pancreatic secretions are vital because one of their primary jobs is to neutralize the acidic chyme coming from the stomach, and that's accomplished via the production of bicarbonate, as well as facilitate the chemical digestion of the macronutrients that are contained in the chyme. That includes, of course, the polysaccharides, the peptides, and the fats. And this is accomplished by pancreatic lipase, pancreatic amylase, disaccharases, and in addition, a host of peptidases that are secreted by the pancreas that all have different specificities. So if we look here at the enzymatic component of the pancreatic juice, we see trypsinogen, chymotrypsinogen, procarboxypeptidase, pancreatic amylase and lipase, and also enzymes that break down the nucleic acids DNA and RNA. Now, one of the things to notice about especially these components of the pancreatic juice that we'll circle here in red, I want you to notice these little endings here. Inogen, okay, and pro. These all indicate that these three secretions are proenzymes, or you could think of them as pre-enzymes. And what that means is that they have yet to be activated by the cells that produce them. They don't actually become triggered until they hit the lumen of the duodenum, at which point a cascade of enzymatic interactions will convert trypsinogen into, let's see here, trypsinogen will become just trypsin. Okay. Chymotrypsinogen will become chymotrypsin. And procarboxypeptidase will become carboxypeptidase. There's also an aminopeptidase that works at the other end of the peptide. The purpose of this is so that these powerful proteolytic enzymes aren't prematurely activated inside the cells that secrete them, otherwise it would destroy those cells. And in point of fact, sometimes what can happen when the pancreatic duct gets blocked is that these proenzymes can auto-activate to some extent and can begin to digest the pancreas, and that can contribute to inflammation and sometimes destruction of the organ. So this is a strategy that we've already seen in pepsinogen in the stomach, which is made by the parietal cells, by the chief cells, in the form of pepsinogen, which is inactive till it hits the lumen of the stomach, and at that point the hydrochloric acid and any activated pepsin will cleave covalent bonds, thus activating the enzyme. And the point here again is to preserve the integrity of the cells that generate these powerful secretions, because remember, there's quite a lot of protein content in these cells. If these enzymes were allowed to run wild, they would obviously destroy the cell that creates them. The amylase is there to break down starch, the lipase fat, and of course the DNA and RNA are broken down by the deoxy and ribonucleases. There's an interaction of the duodenal and the pancreatic enzymes. Enterokinase from the duodenal mucosa is attached to the brush border, and it helps activate trypsinogen to form trypsin, which activates chymotrypsinogen to form chymotrypsin, which activates procarboxypeptidase to form carboxypeptidase. And what happens is that this cluster of enzymes, as a result of their combined activity, serve to break peptides ultimately down into individual amino acids. The pancreatic amylase continues starch digestion while lipase digests the lipids. And of course the DNA and RNA are broken down by the deoxy and the ribonucleases respectively. If we look here at bicarbonate ion production in the pancreas, we see a very interesting set of chemical reactions, enzyme catalyzed, which ultimately produce the bicarbonate content of the pancreatic juice. You start with water and CO2 via the action of carbonic anhydrase forming carbonic acid. And let's pick a nice pen color. Let's go with blue here. So you can see the carbonic acid formed here. Okay. The next thing that happens is that carbonic acid is going to be broken down into bicarbonate and free proton as a result of the natural dissociation of carbonic acid in the cytoplasm, which is mostly water. So you can see the bicarbonate here. The bicarbonate is going to be transported via an antiporter directly into the intercalated duct lumen for exchange of chloride. You can see that action here. There's the bicarbonate. There's the chloride coming back. And what this does is this preserves the charge across the membrane, at the same time getting the bicarbonate closer to the pancreatic duct. The next thing that's going to happen is that the ions and the water are going to move through the intercalated duct towards the interlobular duct, and once we do that, essentially we've accomplished our goal of becoming part of the pancreatic juice. Okay? Notice at the same time that we've got an antiporter swapping protons for sodium, and any imbalance in electrical charge is offset by the fact that these both have a +1 charge. The sodium is in turn going to be pumped through the intercalated duct lumen to become part of sodium bicarbonate. Okay, so this will move also ultimately into this container. And any other excess sodium is going to be sent back across the plasma membrane by the sodium-potassium ATPase. That pumps action you can see illustrated here. Okay. Now you might well ask, okay, well, what happens to the protons? Well, the protons are going to be picked up by any hydroxyl ions that spontaneously form in the water content of plasma to form water. There will be a slight acid tide in the blood, but essentially the carbonic anhydrase in the RBCs is going to take care of balancing that reaction. Okay, so what will happen in this event is that free protons will be combine ultimately with bicarbonate and will form carbonic acid and will ultimately generate carbon dioxide and water once we get back to the lungs. Okay, so it'll become part of that equilibrium. How is pancreatic secretion controlled? Well, again, it's an interplay of endocrine secretions and also nervous innervation. Parasympathetic stimulation by the vagus causes the pancreas to generate a secretion that's rich in enzymes, so the proteases, the lipases, and the amylases are all triggered for release. Secretin from the small intestine, specifically the duodenum, is also going to stimulate the pancreas to release the bicarbonate component of the pancreatic juice. This generally happens at the same time that CCK is released. You can see the CCK here. Let's pick, I don't know, gray for this one. This hormonal signal here is sometimes abbreviated CCK. Okay. And CCK has a two-pronged function. It helps the pancreas secrete an enzyme-rich component into pancreatic juice. It also, though, targets the gallbladder, forcing it to squeeze to release the bile into the duodenum along with the pancreatic juice. So CCK is a pretty important short-acting hormone. You can see here that it has a very specific set of targets. What triggers the release of secretin and CCK by the duodenum? The initial entry of chyme into the first part of the duodenum. As soon as the chyme hits, the pH is going to drop. That drop in pH is the signal to generate the secretin and the CCK, and they have to act relatively quickly in order to get the bicarb and the enzymes into the duodenal chamber so they can mix effectively with the chyme coming from the stomach. Once we spend our time going through the small intestine and absorbing the bulk of the nutrients, we're eventually going to find ourselves at the beginning of the large intestine via the ileocecal valve. The ileum leads directly into the cecum at the ileocecal valve. By the time the material that's left in the small intestine gets there, the nutrient content has been abrogated to the blood supply, and all that's left in terms of our metabolism is waste products. So the large intestine runs from the ileocecal junction all the way to the anus, and it consists of the cecum, the colon, the rectum, and the anal canal. The movements are slow compared to the small intestine. Chyme is converted to feces in this part of the GI tract. Main thing that happens here is bacterial degradation of waste products and absorption of water and salts. Mucus is secreted to lubricate the fecal material, and that helps it to slide through. About 1.5 liters of chyme enters the cecum, and 90% of the volume gets reabsorbed, and it gives you about 150 mils of fecal material, depending on how long it sits in the colon. The longer the fecal material sits in the colon, the more water is going to be absorbed. If it sits too long, we're going to tend towards constipation. If the fecal material moves through the large intestine too rapidly, we're going to tend towards diarrhea. The only muscular component of the large intestine is this little strap of smooth muscle tissue called the Tenier coli. Okay, you can see this little strap labeled here, but it's just this little strap of tissue that runs all along, and it's the contractions of the Tenier coli that produce these little pouch-like features on the large intestine that are called haustra. You can see a haustra there, there, and there, and so on. So the musculature of the large intestine is dramatically reduced compared to the rest of the tract. It's sufficient to push the fecal material out, but the reasoning behind why there's so little muscle in the large intestine compared to the rest of the GI, the best explanation I have is that the less powerful the colon is, the less likely it is to be damaged. The lining of the colon is, relatively speaking, delicate compared to stratified squamous. It's a simple epithelial layer with a lot of goblet cells for mucus secretion. But I can imagine that if there were vigorous peristaltic waves and perhaps a significant mass of fecal material, you could imagine that the colon could easily rupture. So that would be my guess as to why there's less muscle in the large intestine than in the small. Honestly, I haven't really found a great explanation for it. If we look at the anatomy of the large intestine, the cecum is a blind sac, and the bottom of the cecum contains the appendix, which contains a lot of lymph nodules and also bacteria. It was once thought that the appendix was essentially a vestigial organ, aka useless, but it turns out that the appendix is a site of bacterial cultural activity. In addition, its job as lymphatic tissue helps to alert the immune system to the presence of pathogens. If you look in the lymphatic tissue in the appendix, what you'll find is a significant number of lymphocytes and macrophages. The colon has 4 parts: an ascending, a transverse, a descending, and a sigmoid section. There's a circular muscle layer that is complete, and a longitudinal layer that's, as we said, relatively incomplete. The Teniae coli are basically all there is to the longitudinal muscle. Contractions of these Teniae coli form the haustra, and there are also small fat-filled pouches that dangle from the Teniae coli that are called omental appendages or epiplotic appendages. The mucosa has a lot of straight tubular glands labeled crypts, and the goblet cells predominate making the mucus, but there's also absorptive and granular cells in that region as there are in the small intestine. But notice that when you look at the large intestine compared to the small intestine, that the surface area is dramatically reduced. The rectum is a straight muscular tube and has a thick muscular tunic. The anal canal has a superior epithelia that's simple columnar and an inferior epithelia that is stratified squamous. And now you can appreciate the use of this tissue in this region. Stratified squamous tissue is less likely to tear. There is considerable power near the rectum and the anus, and as a result, we want to sort of support the tissue that's going to be in contact with the fecal material so it doesn't tear, hence the choice of stratified squamous. The internal anal sphincter is made up mostly of smooth muscle, the external anal sphincter, skeletal muscle. Hemorrhoids are essentially varicose veins of the anal canal. They're very uncomfortable. In addition, they represent a danger. Because of their location, they can easily rupture and bleed and become infected. And the danger there, of course, is you could go septic. So if you suspect you have hemorrhoidal tissue, you want to see your GP or your proctologist as soon as possible. What does the large intestine secrete? Well, mostly mucus to lubricate the fecal material. Parasympathetic stimulation increases the rate of mucus secretion. And there are pumps. The bacteria generate acids, and the following remove acid from the epithelial cells that line the large intestine. There's an exchange of bicarbonate for chloride, as well as an exchange of sodium for hydrogen. And the bottom line there is that you're going to end up generating ultimately carbonic acid. Bacterial action produces gas, and of course mostly the gas is methane. It's the indole and the skatole that are sulfur compounds that provide the odor. Basically, if we consume large amounts of legumes in our diet, beans, main legume there, and artificial sugars, what can happen is that the gas production can go way up. The bacteria, though, also provide useful components. Vitamin K and the B complex vitamins are byproducts that are useful in metabolism, and so this represents what we call in biology a symbiotic relationship between our gut bacteria and our digestive system and really our entire physiology. The bacteria get a place to live and they get a food supply, and in turn we get their byproducts. What is in the feces? Well, it's water, mostly fiber, a lot of bacteria, and of course there's going to be intestinal lining in there as well. And that's to be expected because there's a lot of, physical trauma that the lining of the GI experiences as the food and the waste material go through the pipe. Okay, mass movements are common after meals, and they're integrated by the enteric plexus. Remember, that's that nerve net that permeates the muscularis externa and helps to coordinate peristaltic movement. Local reflexes are instigated by the presence of food in the stomach and the duodenum. The gastrocolic reflex is initiated by the stomach, and the duodenocolic is initiated by the duodenum. And what is this reflex? Well, it triggers defecation. Okay, and the idea is you want to move stuff out of the distal end of the pipe so that the food in the part of the pipe superior, right upstream, can make it successfully through the tract. The defecation reflex is triggered by a stretching of the rectal wall by the fecal material. Parasympathetic stimulation also helps to promote movement. It's usually accompanied by voluntary movement to expel the feces. The Valsalva maneuver is a typical attempt to try and evacuate. Okay, you tense the abdominal muscles, pressing the abdominal wall and the organs up against the large intestine, and that, along with the relaxation of the external anal sphincter, allows the fecal material to be expelled. So let's take a look at the reflexes that govern activity in the colon.
The presence of food in the stomach and chyme in the duodenum stimulates mass movements in the colon. Mass movements are integrated by the enteric plexus. They propel the contents of the colon toward the rectum. The presence of feces in the rectum stimulates parasympathetic and local reflexes that result in defecation.
Okay, digestion is defined as the breakdown of food molecules for absorption into the blood. Mechanical digestion physically breaks down food particles into smaller chunks, while the chemical digestion helps to disassemble the macromolecules into their building blocks. So if we're talking about proteins, the ultimate goal is to break down the proteins into amino acids. If we're talking about complex carbohydrates, the ultimate goal is to break that down into simple sugars. And if we're talking about fats, generally what we produce are free fatty acids and glycerol, which end up being inculcated into structures called chylomicrons and lipoproteins for their ultimate transport through the lymph and in the blood, where they'll eventually find their way back to the liver, hopefully, most of the time. Absorption and transport is simply the movement of molecules out of the digestive tract and into the circulation for distribution throughout the body. And so what you're looking at here is just a flow chart showing you where the carbs, lipids, and the proteins go after we consume them, right? So you can see the journey beginning in the oral cavity. Mechanical digestion commences here along with chemical digestion of starch and a fat. Eventually we make our way into the stomach, where hydrochloric acid and gastric lipase and pepsin are going to act on lipids and proteins respectively. And then in the duodenum we really begin chemical digestion in earnest. Remember that the pancreas and the gallbladder contribute here. The bile salts are the emulsifiants, and the pancreatic enzymes are going to break down in kind carbohydrates, pancreatic amylase doing the bulk of that, as well as disaccharides, disaccharases, which are in the duodenum and all along the small intestine. And the bile salts serving as the emulsifiant, acting with the pancreatic lipase, help to break the fat content of your diet down into glycerol and free fatty acids. And then, of course, the combined action of the remaining peptidases, trypsin, chymotrypsin, carboxypeptidase, aminopeptidase, all act in the duodenum to break down proteins into their component amino acids, and they'll eventually find their way into the blood. So what will happen here with the sugars and the amino acids is they'll move into the blood as they progress from the duodenum to the jejunum to the ileum. The lipids, as it turns out, are going to take a rather circuitous route. They're going to enter lacteals as chylomicrons, and then they'll eventually join the circulation where the lymphatic and the circulatory systems hook back up at the right and left subclavian veins. And then the venous return will eventually bring them back to the liver. Okay, um, so this is just a look at how we deal with carbohydrates in the small intestine. Glucose is going to be absorbed by symport with sodium into the intestinal epithelial cells. And this is driven by a gradient that the sodium-potassium pump establishes. The glucose then moves out of the interstitial epithelial cells by facilitated diffusion and then enters the bloodstream, which is comparatively glucose poor. And where does it go next? It goes to the liver. And what will the liver do with it? The liver will either store it as glycogen, which is essentially a glucose polymer, or will disassemble it and convert it into fat in the form of triglycerides. In the event that the body needs those calories immediately, that glucose may actually be sent straight on into the hepatic vein, into the inferior vena cava, and join the general circulation, where it'll eventually meet up with metabolically active tissue. But most of the time what happens is right after a meal, we enter what we call the absorptive state, where what we're doing primarily is stoking the body's pantry, producing fat stores, producing glycogen for later use. The glucose gets transported to the cells that need energy, and insulin, of course, is going to influence the rate of transport. Insulin is the signal to the body to either store the glucose for later use as fat or as glycogen, or for the cells that need it for energy to pick it up out of the blood and use it to make ATP. What happens to the lipids is that they're going to get broken down into free fatty acids and glycerol, reassembled into chylomicrons. This all happens via the action of lipase and the assistance of the bile salts. The chylomicrons are going to get transported into the intestinal epithelial cells, and there they'll be imbued with proteins that are going to assist this now a lipoprotein conglomerate. Think of it as a little fat carrying vehicle. Will enter the lacteals and eventually is going to find its way back to the venous return near the subclavian veins. Eventually what will happen is these lipoproteins will find their way to the liver, and then the liver will deal with the lipid component either to store it for later use or potentially to pass it on to the rest of the body. Bottom line, if you have your blood cholesterol checked, we should probably touch on this just briefly here. There's different types of transport vehicles that carry the lipids around the bloodstream. Okay, you've got your chylomicrons. You've got your LDLs. You got your VLDLs. And you got your HDLs. And of these, there's only one that we would consider the good cholesterol, and it's this guy, the HDL. The HDL indicates that we're scavenging lipids and transporting them either for metabolism or perhaps bring them to the liver. When you're high in these other types of lipids in the plasma, what this tends to indicate is that you're going to, in all likelihood, deposit them on the linings of the blood vessels. Okay, and that's going to end up promoting hypertension and also increasing your risk for heart attack or stroke. Lipids include triglycerides, phospholipids, steroids, and fat-soluble vitamins, A, D, E, and K. The bile salts surround the fatty acid and glycerol and form the micelles. And then we generate now these different lipoproteins. The chylomicrons are 90% triglyceride and 5% cholesterol, 4% phospholipid, and 1% protein. They enter the blood and they travel to adipose tissue. In the blood, the triglycerides are converted back into fatty acids and glycerol. where they're transported into adipose cells and converted back into triglycerides. Lipoproteins are the rest of the lipid transport family. All lipids carried into the blood are done so in combination with protein so that they can dissolve in plasma. You remember, oil and water don't mix, and so you have to create a vehicle to move them around. Cholesterol is about 15% ingested and 85% made in the liver and the intestinal mucosa. Lipids are lower density than water, and proteins are higher. So the chylomicrons we've already talked about. The VLDLs are 92% lipid and 80% protein, and they are a form in which lipids leave the liver. Triglycerides are removed from VLDLs and stored in adipose. In the VLDL, then it gets converted into an LDL. The LDLs are 75% lipid and a quarter protein, and they transport cholesterol to the cells. The cells have LDL receptors that pick them up and internalize them. The number of LDL receptors becomes less once a cell's lipid cholesterol needs are met. And so what happens is those receptors get downregulated. And then the HDLs are 55% lipid and 45% protein. Here we transport excess cholesterol from the cells to the liver. And so what we're doing is we're scavenging it out of the blood and storing it for later use. So the HDL is the one that you want to have in abundance. The LDLs and the VLDLs and chylomicrons, those generally indicate bad cholesterol. And remember, all these guys are going to get into the blood via the lymphatic system. Now, something else that we should note here is that one of the things that can occur with the abundance of these bad lipoproteins, the VLDLs, the LDLs, and the chylomicrons, is the production of fatty plaques on the walls of arteries. That holds a great health risk, because what it'll do is it'll increase the overall blood pressure due to the fact that the arteries are going to become narrowed. Okay, the higher the blood pressure, the more likely you are to rupture a capillary bed and choke off blood to downstream tissues. In addition to that, as blood tries to flow through these constricted areas, the flow will slow down and the blood's more likely to clot, and that will increase, obviously, your risk of heart attack, stroke, pulmonary clot. Any number of dangers result from these emboli. Okay. In addition, the plaques themselves can get knocked loose from the blood vessels, and they themselves can become emboli and represent a danger as well. So this is one of the reasons why we want to keep our lipoproteins with a relatively healthy profile, which means skewing more towards the HDLs. There are genetic conditions where you're going to have elevated cholesterol due to a genetic lack of these receptors that internalize these lipoproteins. It's called familial hypercholesteremia. And what happens in that event is that even if you have a relatively low cholesterol and lipid content in your diet, your blood cholesterol is going to be high simply because you lack these receptors. So there are medications out on the market to try and control this. Diet can go a long way, but it in and of itself is often not sufficient to try and control familial high cholesterol conditions, and so we recommend medication as an adjunct. So this is how the LDL gets driven into the cells. The cells have pits on the surface. They contain the receptors for the lipoproteins. The lipoproteins bind to their receptors, and then the pit gets internalized. This is endocytosis, particularly this is receptor-mediated endocytosis, and then we supply the cell's needs for the cholesterol and the lipids that are contained in its vehicle. Now, pepsin begins protein digestion in earnest in the stomach. It breaks proteins into polypeptide chains. The proteolytic enzymes produce small peptide chains such as dipeptides, tripeptides, and amino acids. And after absorption, the amino acids are carried through the hepatic portal vein to the liver, which will then, in all likelihood, use them to synthesize protein. That's probably going to be the bulk of what happens to the amino acids, and then To a lesser extent, they will be deaminated or transaminated and used to generate glycogen and fat. So remember that the primary purpose of amino acids are to serve as building blocks. So this is just a look at how amino acids are transported. Acidic and neutral amino acids are absorbed by symport into the epithelial cells. The symport's driven by the sodium-potassium gradient. So what you're seeing here essentially is that the amino acid and the sodium come in basically via the same carrier. The amino acids then move out of the intestinal epithelial cells and enter the capillaries of the intestinal villi, and then the hepatic portal vein is going to receive that, and then the liver is going to deal with that as it sees fit. And again, most of this will be used to synthesize other proteins, and then the bulk of the rest of it is going to be used to generate fat and glycogen. Okay. Water can move in either direction across the wall of the small intestine depending on the osmotic gradient. Ions, sodium, potassium, calcium, magnesium, and phosphate are actively transported. The water, of course, will follow passively in the direction of the greatest osmotic pressure. Okay. One of the things that we have to appreciate about the digestive system, as with all other body systems, is that its efficiency decreases the older we get, due primarily to the death of cells and the subsequent death of tissue, and that's going to decrease organ function. We see a reduction in the mucus layer, reduction in the amount of connective tissue, and reduction in the amount of secretions, and also the muscles that move the food along the tract become weaker. And the result of this is reduced peristalsis, and what we know happens in the large intestine is this promotes constipation. So one of the things that we can't stress strongly enough is the inclusion of fiber in your diet as early as possible in order to remain regular. The fiber in the colon helps draw water into the fecal material, loosens it, and makes it easier to pass. And this is one of the reasons why, especially in the pantry of people over the age of 65, if you look, you'll either find a fiber supplement or fruit juice or prune juice or fresh fruit as a way of trying to remain regular. Increased susceptibility to infections, also prevalent, and toxic agents can promote disease. You also see an increase in the incidence of ulceration and cancer. And the cancer is, again, simply a function of long life. If you live long enough, those random events that produce changes in the DNA, eventually a few of those are going to slip by the immune system, and you can establish a primary tumor which could perhaps go metastatic. The ulceration is, again, primarily, in some cases, due to Helicobacter. We discussed how Helicobacter can attack the stomach lining, okay, and promote bleeding and in some cases perforation. The other reason for the ulceration simply is the loss of lining, okay, due to the death of the cells, which can compromise the integrity of the tract, okay, and cause it to bleed, resulting again in inflammation and tissue damage. So it's another aspect of digestion that sees a decline as we age. Another thing we should point out is that the walls get weaker as we get older, and so we're going to have a tendency to form diverticula. This will result in diverticulosis, which, if they become inflamed, produces diverticulitis. Very unpleasant condition in which these blind pouches can become inflamed and produce irritation, distension, and discomfort, and represent this really same kind of risk that appendicitis does. And of course, the other thing we have to acknowledge about the digestive system is that our sense of smell and our sense of taste decline as we age, and so food becomes less appetizing. And the less appetizing food is, the less pleasurable it is to eat. The less food you eat, the fewer calories you have. The fewer calories you have, the less energy you've got. The less energy you have, the less capable the body is of affecting repair and maintenance. Okay, so that's another downside of the digestive system as we get older. Okay, all right. Again, review this material. It will show up on the PRS, and I'll see everybody in class. Talk to you later.